Welcome to the Deep Dive. We're your shortcut to getting really well informed on urgent topics.
That's right.
Today, our mission is to dive into the source material you sent on a pretty critical medical condition. We'll pull out the key insights so you can grasp the essentials fast.
Let's do it.
And we're jumping right in with a scenario. Put you right there in the emergency room.
Okay.
Picture this. A 30-year-old man, clearly in distress. He comes in with sudden, really severe chest pain. And this pain hit him hard right after he'd been vomiting forcefully, repeatedly.
Okay, that's a key detail.
Yeah. And he's sweating buckets. Diaphoretic is the term. You can just see he's uncomfortable.
Right.
And his vitals, they're definitely setting off alarms. Blood pressure's low, 100 over 65.
Not good.
Heart rate's way up, 115. Breathing fast, 24 breaths a minute. And his O2 sat is dipping 94% on room air.
So he's clearly unstable.
Exactly. But here's where it gets, well, even more specific, even before imaging. On the physical exam, you actually feel crepitus on his chest wall. You know, that crackling under the skin.
Like Rice Krispies, yeah. Subcutaneous emphysema.
Right. And listening to his heart, there's this weird crunching sound with every beat.
Hamman sign, sometimes called that. Very suggestive.
Okay, Hamman sign. And his first chest x-ray comes back quick. It shows a widened mediastinum, meaning something's wrong in the center of the chest.
Right.
Right. And more of that subcutaneous emphysema confirming the air leak.
Yep, the air's escaped somewhere it shouldn't be.
So the big question the source material asks is, what's the next best step? Because all these signs are pointing towards something serious. Boerhaave syndrome.
That's exactly where this is heading. You're right. This whole picture is highly suggestive, I'd say characteristic, of Boerhaave's syndrome.
Okay, so what is Boerhaave's exactly?
So Boerhaave's syndrome is a spontaneous esophageal perforation. Basically, a sudden, full-thickness hole or rupture in the esophagus.
Full thickness, not just a tear.
No, right through the wall. And it's typically triggered by that kind of immense pressure from forceful vomiting. It's a surgical emergency.
Wow.
And you often hear about something called the macular triad with Boerhaave's.
Macular triad.
Yeah, that's vomiting, chest pain, and the subcutaneous emphysema, the crepitus you mentioned.
Which our patient has. All three.
He does. But it's really important to note this triad is variably present. That's the term used.
Meaning you don't always see all three.
Exactly. You might only see one or two. So you can't rely only on the full triad to suspect it, which makes diagnosis tricky sometimes.
That makes sense. So going back to the x-ray findings, the widened mediastinum and the subcutaneous emphysema, what do those tell us specifically?
Well, the widened mediastinum is a big red flag. It means air, or sometimes fluid, from that ruptured esophagus is filling up the space in the center of the chest.
Pushing things aside.
Potentially, yes. And the subcutaneous emphysema, that air under the skin, it directly tells you that air has escaped from inside, from the esophagus or airway, and it's tracking through the tissues.
It's literally leaking out.
It is. And sometimes you might see other things on the x-ray too, like pneumomediastinum, which is just a more specific term for air in that central chest space, or even a pleural effusion.
Fluid around the lung.
Yeah, often on the left side, interestingly, it's leakage accumulating.
Okay, the urgency here feels really high. So if you suspect Boerhaave's, what's the definitive test? How do you confirm it quickly?
Right, time is critical. The next best step, the gold standard really, is a contrast esophagogram. But crucially, using a water-soluble contrast agent.
Water-soluble, why that specific type, like gastrographic?
Exactly. Gastrographin is a common one. You use water-soluble contrast because if it leaks out of the esophagus, which is what you're looking for, it's less irritating to the surrounding tissues, like the mediastinum, compared to, say, barium. Yep. So the patient swallows this contrast, you take x-rays, and if there's a perforation, you'll actually see the contrast leaking out of the esophagus. It pinpoints the leak.
That seems very clear. But I can imagine other things might pop into your head in an emergency.
Sure.
The source material mentions why some other approaches aren't right here. Can we touch on those? Like, why not endoscopy first?
That's a really important point. Endoscopy, sticking a camera down the esophagus, might seem logical to look for a tear.
Right.
But it's actually not the first-line test here. The risk is that the endoscope itself, or the air insufflated during the procedure, could actually make the perforation worse, extend the tear.
Oh, wow. Okay, so it could do more harm.
Precisely. It's generally saved for cases where the contrast study isn't clear, or maybe later for therapeutic reasons, but not for the initial diagnosis.
Got it. And what about just giving something like a proton pump inhibitor,
for acid,
and sending the patient home?
That would be a disaster in this case. That approach might be okay for something like a Mallory Weiss tear.
Which is different.
Very different. A Mallory Weiss tear is usually a partial tear, just in the lining, the mucosa, also often from vomiting. But Boerhaave's, remember, is full thickness. It's a rupture.
Okay, apples and oranges.
Completely. Boerhaave's needs urgent, immediate intervention. Treating it like a simple tear and discharging would likely be fatal.
Okay, that distinction is critical. And the last, why not? Placing a nasogastric tube and just observing.
Right. So conservative management might be an option. Keyword might, but only for very small, contained perforations in patients who are completely stable.
Which this patient clearly is not.
Not at all. With his low blood pressure, high heart rate, fast breathing, the X-ray findings, he has systemic signs of illness. This demands urgent diagnosis confirmation and immediate surgical consultation. Observation isn't appropriate here.
This really paints a picture of how fast things go downhill. So, diagnosis confirmed or even strongly suspected. What happens right now to save this patient's life?
Okay, immediate actions. First, urgent surgical consultation. Most cases of Boerhaave's require surgery to repair the hole. That needs to happen ASAP.
Get the surgeons involved straight away?
Absolutely. Simultaneously, you start broad-spectrum IV antibiotics. Think infection control contents from the esophagus leaking into the chest cavity are a recipe for severe infection, sepsis.
Right, makes sense.
And fluid resuscitation. Remember his low blood pressure. You need to support his circulation aggressively with IV fluids.
Okay, surgery consult, antibiotics, fluids, anything else?
Yes. Keep the patient NPO nothing by mouth. Absolutely nothing.
Don't want anything else licking at it.
Exactly. And start 5E proton pump inhibitors. That helps reduce stomach acid, which can further irritate the injured esophagus.
So it's a multi-pronged, immediate attack.
It has to be. And the key message, really the takeaway from all this, is that early recognition and management are everything.
Why is timing so crucial?
Because delays in diagnosis, even just by hours, significantly increase the mortality rate. Boerhaave's syndrome is incredibly lethal if not treated promptly. The longer the delay, the worse the outcome.
Wow. That really underscores the importance of piecing together those initial clues, the vomiting, the pain, that crunching sound, the X-ray.
Every detail matters in getting to that diagnosis quickly.
This deep dive absolutely shows how seemingly separate symptoms can suddenly click together to reveal a true life-threatening emergency like Boerhaave's. It really highlights the need for precise diagnosis and just immediate action.
Couldn't agree more.
It really makes you think, doesn't it? You know, what other symptoms, maybe things that seem less dramatic initially, might be hiding equally urgent conditions that we should all be more aware of? Something to ponder